Very good morning to all of you. My name is Arosha Disanaka. I'm the president of the Ceylon College of Physicians. Welcome to the December Young Physicians Forum of the Ceylon College of Physicians. We will have both the Young Physicians Forum, where two of our bright emerging stars in medicine will speak to us on very timely topics, as well as followed by the college lecture scheduled for later this afternoon. And then since this is the very final Young Physicians Forum that I will be chairing as the president of the CCP, you all know that the CCP AGM will be held in about 3 days' time, and then at which time Dr. Duminda Munidasa will take over as president of the CCP. It is my very pleasant duty to thank everybody who supported in this program throughout the year. All the young physicians who spoke at this forum. Listening to them, I'm convinced that medicine in Sri Lanka is in good hands. They're all very brilliant people. Then, of course, all the specialists who delivered college lectures at this forum. Thereafter, the judges who actually sit through this, it's not an easy task to sit through all these presentations, award marks, ultimately select the Vijay Ram Prize winner for that year. So my heartfelt gratitude to all the judges who made this possible. Then, of course, Nalin and the IT team, which made this an excellent forum for those who are joining online. Even today, we are live streaming this on Facebook, etc. So many people are joining, not just the webinar, but the multitude of forms for disbursement of knowledge. So thanks to Nalin as well. And during the initial stages, we had this program at the ClinMark, so ClinMark staff. Again, thank you very much. Subsequently, we started doing this online for the benefit of, at the time of the fuel crisis, etc. But we continue to do this online. We feel that it's probably the way forward, really, having a lesser carbon footprint and contributing towards less fuel consumption for all. And considering the return on investment, I think this is probably the best form to do this. So thank you everybody for making all this possible. It has been great working with you all. So it is my great pleasure to both chair this last session. My secretaries might join later and take over. It is my great pleasure to warmly welcome all in the audience who joined us over the past few months, and then hand over to the first young physician who will be speaking today. That will be Dr. Supun Taraka Wijayawardena. He is a senior registrar in endocrinology at the Sri Jayawardhanapura General Hospital. And his topic will be diabetic gastroparesis management and update on the management of diabetic gastroparesis, which perhaps is a fairly neglected area in medicine at the moment. So I look forward to listening to Dr. Wijayawardena. Over to you, Dr. Wijayawardena. Thank you.
At the outset, I would like to thank the Ceylon College of Physicians for giving me this great opportunity to discuss in this prestigious forum. So next 25 to 30 minutes, I would discuss about the key areas about of what is diabetic gastroparesis, the impact of gastroparesis, a bit about the pathophysiology, clinical presentation, what are the diagnostic modalities available in other countries as well as in our setup, and the management aspects, how we can improve the patient care. So what is gastroparesis? The most important question. So gastroparesis is a motility disorder with cardinal symptoms. Particularly, these patients have early satiety and postprandial fullness. Those are the clinical presentation they would come up with. And as well as we have to prove there is an objective documentation of delayed gastric emptying of solid food, as well as the most important other factor would be we have to exclude mechanical obstruction. That should be by the imaging guided, probably upper GI endoscopy or equivalent. Particularly in the past, they have done the barium studies. So a bit about the epidemiology. So as we know, the type 2 diabetes is a pandemic with the obesity, but with regard to gastroparesis, the most common cause for the gastroparesis is type 1 diabetes. It's particularly long duration, more than 10 years with microvascular complication is a predominant risk factor for the gastroparesis, as well as it is a tip of the iceberg phenomenon also, because most of the patient will come with vague symptoms. With the busy schedules, we also neglect this area as mentioned by our chairperson. So about 1/3 to 1/2 of the moderately controlled diabetes, both with type 1 and type 2, will have either imaging evidence or most of the time clinical evidence. Initially, they have asymptomatic disease. I have spoke about the epidemiology, particularly the type 1 diabetes is more common than the type 2, and the female to male predominance was there. Particularly, there was a female predominant features because they have high progesterone, and the prevalence increases with aging as well as the duration of the diabetes, and associated microvascular complication is a well-recognized complication. Poor early glycemic control is one of the important area I would like to emphasize, because we have to control the diabetes in the early onset compared to the later onset. Once this condition established, it is difficult to reverse, but early onset poor good glycemic control can prevent this condition. So why it is important to know about the gastroparesis for the patient perspective, as well as the physician, as well as healthcare perspective, because it has increased morbidity as well as increased mortality of the patients, particularly type 1 diabetes patient I mentioned previously. Some of the studies has shown, particularly Diabetes and Digestive and Kidney Disease Consortium study has shown type 1 diabetic patients are more prone for hospitalization with gastroparesis, particularly with vomiting, dehydration, and ultimately leading to diabetic ketoacidosis. As well as, these patients are living with poor quality of life. They can't eat what they want and they can't live as they want. And as well as because of that, significant psychological impact has been detected. Particularly, these patients have 50% of these patients have anxiety or moderate to severe depression in epidemiological studies. That is one of the studies they have shown here. And increased mortality, particularly 5-year survival has significant reduction, particularly age and sex matched to these patients to the community population. 67 to 81% reduction of survival with regard to 5 years. As well as one of the other key area I want to emphasize is the glycemic variability, because this gastroparesis sometimes it functions as that tachygastria. That means very fast it will, that means these chyme, I will discuss about the pathophysiology, they will pass into the duodenum. And sometimes they are very slow to go into the duodenum. So the blood glucose levels we cannot predict. It is very unpredictable. So they are more prone for severe hypoglycemia with hypoglycemic unawareness, as well as difficult to control the blood sugars with hyperglycemia. So I will touch about the physiology and the pathophysiology in the next part of my presentation. So as you know, in the gastrointestinal system, it has its own innervation, as well as it gets its innervation from the extrinsic nervous system. So the little brain is the intrinsic nervous system, and the big brain is from our central nervous system. So both are independent on each other, but one of the important thing in the gastrointestinal system is there are the important nerve plexuses in between these muscles. One of them is myenteric plexus, in which there are some important cells, intestinal cells of Cahill. I want to emphasize it is working as a pacemaker, as in Sisse node in the heart. So similar way, it can produce its own impulses, and it conveys messages to the rest of the smooth muscle for the integrated contraction. So the parasympathetic nervous system is one of the important thing in this physiology, particularly vagal nerve. It can cause, when it activated, the sphincters are relaxed. So the opening of the sphincters, particularly the pyloric sphincter, is the important key area I want to tell with regard to gastroparesis, as well as it excites the non-sphincteric muscles, which are important in the propagation of this mixed food, that chyme, which is produced inside the stomach, to propagate into the duodenum in coordinated manner. So you can see in this cartoon, in the upper part, it shows the normal physiology, and the lower half, you can see there is a pathophysiology involved in the gastroparesis. So for the footballers, once we get a footballers via the esophagus, the footballers comes into the fundic area of the stomach. So it is the main area of food accommodation. So food accommodation is very important in the normal physiology. So these patients do not have high capacity of fundic accommodation, because these nerve that I mentioned, these specific nerves in mesenteric nervous plexus, they have these cells which can produce a lot of nitric oxide. So nitric oxide, as you know, is which causes smooth muscle relaxation. So when your smooth muscles are relaxed, you can accommodate more food. So in these patients, they cannot accommodate more food, so they will feel early satiety and postprandial fullness if you get a large meal. So the next important phase is the gastric phasic contractions. In that condition, in that phase actually, the lower esophageal sphincter is contracted as well as the pyloric area, but the rest of the stomach is, when the food bolsters come, it mixes and grinds it and makes it semi-solid. So that's also very important with the peristalsis later onwards, antropyloroduodenal coordination with the neurohumoral mechanisms, particularly the nervous system as mentioned previously, and the other hormones, gut hormones, particularly motiline, cholecystokinin, and ghrelin. They are some, in the few upcoming slides, I would explain they are therapeutic, that there are new trends of treatment, but still not proven with regard to these molecules. So in these gastroparetic patients, they will have lack of peristaltic contractions. Sometimes they have tachygastria, as you can see, and sometimes bradygastria. And this antropyloroduodenal coordination is not happening properly because of vagal neuropathy, as well as intrinsic nervous system neuropathy, as well as the chyme is not entering into the duodenum properly. So they will have less reduced hormonal mechanisms, as well as because of that, they will go into pylorospasm and later onwards fibrosis of the pylorus, which ultimately lead into irreversible state. So as you know, in the diabetes, because of the hyperglycemia, advanced glycemic end products, so they are deposited in the nerve terminals, and which is toxic to these nerve terminals and causing apoptosis and increased oxidative stress, as well as reduction in the nitric oxide synthase. And sometimes, as we one of the other important mediator recently discovered was the carbon monoxide. So as we all know, carbon monoxide is a lethal gas for us if we inhale more than the normal concentration, but it is also produced inside this nervous plexus, and it causes important two roles. It has a cytoprotective action, as well as it relaxes smooth muscles. So it will help in prevention of the gastroparesis and improves the gastric motility. So with the same time, with the vagal neuropathy and the small intrinsic nervous system involvement, there is myopathy also happening, particularly in the stomach as well as in the small intestine. So this is the summary slide I want to show, that extrinsic nervous system is affected, as well as nitric oxide synthase is not produced enough. So it will cause reduced gastric accommodation, uncoordinated antral contractility, and ultimately pylorospasms. As well as because of this oxidative stress, immune cells in the GI tract also get affected. So type 2 macrophages get affected. So there will be loss of cytoprotective factors, as well as damage to the intestinal cells of Cahal. So Cahalopathy can happen, so which leads to ultimately arrhythmias, either tachyarrhythmias or bradyarrhythmias of the stomach. As well as in the diabetes, as you all know, the IGF-1 levels will be low. So there will be smooth muscle atrophy because of that. So next area I want to talk is what is the relationship of glycemic control with the gastroparesis. It is actually a bidirectional relationship. So when even in a normal patient, when there is a person when there is a hyperglycemia, what should happen is there should be a reduction of that means when there's a hyperglycemia, that chyme release should be minimized to the duodenum to prevent further hyperglycemia. So when there's an acute hyperglycemia, even in a healthy person, it causes delayed gastric emptying. But in gastroparesis, what happens is when there is already there is reduction in passage of chyme, so that will reduce the blood sugars. But when there's a hypoglycemia in a normal physiology, in a person with normal physiology, usually causing increased gastric emptying, but it is not happening in these patients. So that is very important to understand. So we have to avoid the hyperglycemia in the initial phase, as I mentioned previously. Even when the established disease is there, we have to prevent the hyperglycemia to prevent gastric emptying caused by that phenomenon. As well as when we are giving this oral hypoglycemic medications or insulin, if we cannot predict their rate of contraction or pyloric opening speed. So when there is hypoglycemia, it is that in usual person that chyme is increased to the duodenum passage increased, but in these patients not happening. So they can go into severe hypoglycemia with unawareness, even increase the cardiac arrhythmias and mortality also increase. So in one study, they have shown with euglycemia versus hyperglycemia with blood, particularly with type 1 diabetes, with related to gastric emptying half-life when using scintigraphy for the solids, it has delayed 30 minutes when there is hyperglycemia of more than 250 to 300 milligram per deciliter of glucose compared to euglycemic status. So higher the fasting blood sugar, higher the ppbs, the lower the gastric emptying. So does strict glycemic control improve gastric emptying? So it's the other question to be answered. So there are several studies. There were small studies done for the type 1 diabetes as well as type 2 diabetes patients. Whether already established patient with gastroparesis improves with glycemic control. Probably the answer is not, because in both the studies, even they are small studies, they have not shown any significant improvement of gastric emptying with the scintigraphy and other studies, which I will elaborate more in my presentation later. So what's the clinical presentation? So as mentioned previously, the cardinal feature is early satiety with postprandial fullness, particularly several hours after the meal. And they also experience nausea and vomiting when the disease is severe, as well as abdominal pain. Even though they will have neuropathy, some patients may present with abdominal pain, but most may not. And weight loss is one of the important clinical feature we have to think, because they will not take enough meals, because of these symptoms, these people fast for hours sometimes, and ultimately leading to glycemic fluctuations also. And also these patients also can have constipation and diarrhea depending on the small intestinal and large intestinal involvement. So the complications are also self-explanatory. Because of this severe nausea and vomiting, sometimes because of these gastric irritants, they can have esophagitis. Sometimes malarious stare with repeated vomiting and malnutrition. Volume depletion is one of the important areas, particularly in young patients with type 1 diabetes. Actually, there were some case reports, they can push into the acute renal failure also because of that. Along with that, electrolyte disturbances can happen with vomiting and as well as probably with diarrhea. And basal formation is one of the important things I want to highlight. If we take excessive amount of fiber, they can cause basal formation and causing mechanical obstruction on top of the diabetic gastroparesis. As well as some studies has shown type 1 diabetes patients are more chance of having diabetic ketoacidosis, and type 2 patients can have hyposmolar hyperglycemic syndrome because of glycemic variability and drugs they are taking. So the next area, what are the conditions that can mimic gastroparesis? We have to have some idea. Rumination syndrome is one of that condition. They will feel passive regurgitation of unpleasant tasting of substances without preceding nausea. But most of the time, these gastroparesis patients will have nausea and vomiting. And cyclical vomiting syndrome is one of the other things. They have episodic bouts of emesis. Unlike to the gastroparesis, they have persistent symptoms. And cannabinoid hyperemesis, also they have reported several cases. In this case, also they can have features of gastroparesis with gastric peristalsis is diminished but history has suggested they have marijuana abuse. So the next key area I want to emphasize is the diagnostic modalities. So in our practice, the gastric scintigraphy is the major diagnostic modality we are using, but ultrasound also we can use, but it is having less specificity, it's less sensitivity and intraoperator variability also. And other modalities would be stable isotope gastric emptying breath testing, wireless motility capsule, electrogastrography, MRI and SPECT in some centers they are also using. So a bit about the gastric scintigraphy. Before, when we suspect a patient with gastroparesis, we have to take a date from our radiology colleagues, particularly nuclear imaging department. And after that, we have to prepare the patient properly. We have to discontinue all the motility altering medications, particularly prokinetics and anticholinergics, at least 3 days prior to the procedure, because that can alter the gastric motility and it can lead to false positives and false negatives. And long-acting GLP-1 agonists definitely should be stopped 1 week before, because they will retard the gastric emptying, as well as smoking and alcohol. And as mentioned previously, the fasting blood sugar should be less than 275 on the day of the testing, because acute hyperglycemia can lead to delayed gastric emptying. So once these preparations have done, we can give a technetium-99 colloid label. Usually we are giving egg white meal ingested within 10 minutes. And we are imaging the area of gastric area as well as the duodenal area after 1 hour baseline, 1 hour, 2 hours and 4 hours after the meal, and using a gamma camera to see the radioactivity. It's more sensitive to the solids than the liquids, because liquid emptying may remain normal even in the advanced stages. So as you can see, both the normal and delayed gastric emptying, both the patients they are having that radioisotope tracer, 0 hours, both are same. 2 hours time, you can see in the normal person, there is 67% has entered the duodenum, only 33% remaining in the pyloric area. In comparison, delayed patient will have 70% in this case in the gastric area, the pyloric area. After 4 hours time, in a normal person, 100% gastric emptying should happen, and in a delayed gastric emptying, as in this patient, you can see only 57% was entered to the duodenum, and 43% is remaining in the pyloric area. So the gastric emptying is delayed when we are using 2 hour cutoff. If it is more than 60% retention in the stomach or more than 10% retention in the stomach in the 4 hours, we can go ahead with diagnose this patient with gastroparesis. So a bit about the other modalities, gastric emptying breath test, that's useful in, it's a non-radiating no radiation exposure and non-invasive. So we can use in patient with pregnancy and lactation. We are using C13 label substrate, particularly algae substance in the foreign countries. It's a promising alternative in the studies, as well as we are checking how much C13 carbon dioxide is produced with our exhalation with regard to time. So wireless motility capsule, not only the gastric emptying, it can we can look for colonic transit and small bowel intestinal transit times, measurement of with the measurement of pH, temperature, and pressure throughout the GI tract. So as you can see, we are giving 2 centimeter long wireless transmitting capsule with the water and the food substance. And there is a recorder. We are discharging the patient and ask the patient to come back with the recorder after 5 days, because depending on the variability of the gastric emptying, some may take 5 days to pass the wireless capsule through the feces. So as you can see in this graph, in the gastric emptying, if it is more than 4 hours, it is significant. Small bowel, it should the transit time should be 6 hours, and colonic it's around 60 hours, 2.5 days. And whole bowel, that whole gut transit time should be less than 3 days. So as you can see in this graph, there is a significant increment of pH when the wireless capsule entering from gut to the duodenum. So that's the cutoff we are using to diagnose the transit of capsule from gastric to the duodenum. So electrogastrography is another modality. It is very less sensitive. So there are several leads we are placing, like a ECG over the lower chest and the abdomen area. So the normal waveform is 3 cycles per minute. The pre-prandially and post-prandially we are checking, and it has low that false results with heartbeat, respiration, small intestinal and colon motility. So as you can see, normal amplitude is low with the fasting state, and postprandial there is an increment. With the gastroparesis, there will be tachygastria or bradygastria in the lower part of the diagram. So the transabdominal elastography, it's usually done in the research purposes as an invasive procedure during a laparotomy. It's similar to the previous study, but we are using numerous electrodes around 256 to cover whole area of the stomach. So next area is concerned with the management. As you can see, management is multifaceted. So multidisciplinary teams are needed. Not only the endocrinologist or gastroenterologist or the physician are the leaders, but the radiologist, dietitian, gastrointestinal surgeon, clinical psychologist all have a role in managing these difficult customers with gastroparesis. So one of the key areas I want to emphasize is the nutritional interventions, because we are having lack of facilities. So the nutrition is one of the important areas. So we have to hydrate the patient properly. So adequate hydration should be given and advice about the patient, because these patients are more prone for dehydration. As well as we have to ask the patient to eat smaller and more frequent meals, even 6 hourly or 6 meals per day rather than 3 main meals. So meal consistency should be semi-solid or sometimes blenderized depending on the severity of the disease. We should look after their teeth very well, because they have to chew these particles very well, thoroughly, and they have to eat the meal slowly, because once we loaded the stomach with food, the gastroparesis worsen with that. As well as after eating, bit of exercises, bit of walking will improve the gastric motility. So fats is the other important thing. So the fat content should be reduced, but if the patient is severely malnourished, we have to give high dense fat, low amounts. That intake should be 20 to 30% depending on the patient's severity of the disease and the sarcopenia. So the fibers, as mentioned previously, should be avoided as much as possible, because risk of vessel formation and the transit times also increases with fiber. And micronutrient deficiencies are very common in these patients because they are not taking enough meals because of these symptoms. So we have to be vigilant and see these patients, whether the patient is having anemia, B12, features of vitamin B12 deficiency, and bone health. In that case, we have to replace the micronutrients. And body mass index, we have to keep our eye on, because we have to monitor the weight twice a week, ideally. And if the patient's gaining weight,
I'm sorry to disturb you. We have only 5 minutes left.
Okay, I will briefly touch upon the glucose management. So we have to, mainly the glucose management is on insulin, oral medications. There are, as you can see, there are several problems. Metformin you can't tolerate, sulfonylurea, high risk of hypoglycemia, DDP4 inhibitors, absorption issues, and SGLT2 inhibitors. There is a high risk of ketoacidosis. GLP-1 as receptor agonist, as mentioned previously, we have to stop because of delayed gastric emptying. When you are using insulin, you have to use basal or basal plus with we have to use soluble insulin. That means not the rapid acting one. Conventional ones are insulin. We have to sometimes alter our insulin with the patient's severity. The severe hypoglycemia, we have to give the insulin after the meal. So as you can see, insulin is the cornerstone of this management with regard to hyperglycemia. With type 1 diabetes, difficult to control, continuous glucose monitoring has shown significant optimal glucose control, improves antral contractility, and correct gastric dysarrhythmias and accelerated emptying. So a bit about the pharmacological management. This is the latest guideline from the American College of Gastroenterologists, clinical guidelines, August 2022. Still, the only FDA-approved medication is the metoclopramide. So the metoclopramide, we can use 12 weeks maximum, 10 milligrams, 3 to 4 times per week, per day. But the risk of tardive dyskinesia is high, particularly elderly, diabetes, and patients with liver and renal involvement. The recent advance of the metoclopramide, they have introduced nasal route in 2022. It is also FDA approved. Domperidone has a similar efficacy, but does not crosses the blood-brain barrier. So they do not have tardive dyskinesia, and short-term and long-term follow-up studies has shown sustained improvement of gastroparesis up to 2 years in certain studies. So motilin agonist, as you all know, erythromycin and azithromycin, we can use short course, 1 to 4 weeks. There is drawback is tachyphylaxis. So the newer promising medications, they are acting on central nervous system as well as the gut. Particularly, I want to emphasize ghrelin and motilin. We already know ghrelin agonist as well as cannabinoid and neurokinin antagonist. So serotonin modulators, mosapride and levosulpride has upcoming newer evidences. It will enhance the gastric emptying and reduce the postprandial pressures. And neurokinin 1 inhibitor, also one important one, upcoming, but phase 1 study, phase 1 and phase 2A studies only, potential benefit with fundic accommodation. And ghrelin agonist still in the line of upcoming medication, still not enough evidence, but it is promising agent, stimulate gastric body and antral contractions. So the cannabinoid also we can use for these patients.
Dr. Vijayavardhana, because we need to have at least 1 minute for questions.
Oh, okay.
Right? Yes, please.
So the antidepressants also that endoscopic therapy we can use once the patients are refractory to medical therapy. One of the important thing I want to emphasize is the peroral endoscopy pyloromyotomy. It is promising significant quality of life improvement, and scintigraphy evidence of improvement has been shown. So mainly those are the surgical options. Other surgical options are also available, and acupuncture and cognitive behavioral therapy need further evidence. So the take-home messages would be diabetes is the leading cause for gastroparesis. Exclude the mechanical cause of gastroparesis, mechanical cause for the obstruction prior to the gastroparesis diagnosis. Early diabetes control is the key for the prevention of the disease, and the management is multifaceted. So these are my references. I will especially thank my mentor, Dr. Dimuthu Muthukuda, the consultant endocrinologist of Sri Jayawardenepura, for the constant guidance and the supports. So any questions I would like to answer.
Right, thank you. I think we are running short of time. So shall we have one question from the judges, please? One question.
Yeah, I am Dr. Jayanaga, Ananda Jayanaga,
Yes, sir.
one of the judges. Can I ask one question, very, very short question?
Yes, sir.
Dr. Taraka mentioned that it's an excellent lecture anyway. Nitric oxide activity plays a major role in the gastric emptying, isn't it?
Yes, sir.
Yeah. So what is the place for using nitrates in the management of this condition?
So up
like,
to now, they have
mononitrates or whatever the nitrates available?
Yes. So even though the nitrate this can be used, but in the randomized control trials, I have not come up with any evidence to suggest that mononitrates or dinitrates in the use of the gastroparesis, as well as in the latest guidelines also does not give any mention also, sir.
Right. Obviously, cannabinoids have a better place.
Yes, sir. Yes, definitely.
Right. Thank you.
Thank you very much, Dr. Vijayvardan, for your excellent presentation. Thank you again. We will award a certificate which you can see online, and thereafter it will be emailed to you. Thank you once again for participating in the program. Thank you.